Welcome back to the Nurses Study Partner. This is Nephrotic Syndrome, Part 2, the Advanced Tier, in 10 in-depth scenarios. We'll classify the steroid response, reach for steroid-sparing drugs, recognize FSGS and membranous nephropathy, and manage the big complications, vaccines, and relapses. Read each case, weigh all four options, pause to choose, then check your reasoning. Let's begin. Question 1. A 6-year-old with nephrotic syndrome has completed 6 weeks of daily prednisolone at the correct dose, but his urine still shows heavy 3 plus protein and his edema persists. He has never gone into remission. How is his nephrotic syndrome best classified? Option A, steroid-resistant nephrotic syndrome. Option B, steroid-sensitive nephrotic syndrome. Option C, a complete and stable remission. Option D, a single, first, uncomplicated relapse. Pause here and choose your answer. The answer is A, steroid-resistant nephrotic syndrome. Failing to remit after an adequate 4 to 8 week course of daily prednisolone defines steroid resistance. It is not steroid-sensitive disease, not remission, and not a relapse, since a relapse requires having first gone into remission. Steroid resistance calls for a renal biopsy and second-line immunosuppression, and it carries a higher risk of progression. Question 2. An 8-year-old has relapsed 5 times in the past year, each relapse needing high-dose steroids, and he is now developing a rounded face, stretch marks, and slowed growth, though he still responds to steroids each time. Which management change is most appropriate? Option A, give even higher steroid doses at each relapse. Option B, stop all treatment and simply watch for relapses. Option C, ignore the side effects as they do not matter. Option D, add a steroid-sparing agent to reduce steroid use. Pause here and choose your answer. The answer is D, add a steroid-sparing agent to reduce steroid use. This child has frequently relapsing steroid-dependent disease with mounting steroid toxicity, so adding a steroid-sparing immunosuppressant keeps him in remission while cutting steroid exposure. Options include levamisole, cyclophosphamide, calcineurin inhibitors, MMF, and rituximab. Simply giving more steroids, stopping treatment, or ignoring the side effects would all cause harm. Question 3. A child with steroid-resistant nephrotic syndrome undergoes a renal biopsy, which shows scarring affecting parts of some glomeruli, while others look normal, a type that often resists steroids and can progress to kidney failure. Which diagnosis does the biopsy most likely show? Option A, minimal change disease. Option B, focal segmental glomerulosclerosis. Option C, post-streptococcal glomerulonephritis. Option D, a completely normal kidney biopsy. Pause here and choose your answer. The answer is B, focal segmental glomerulosclerosis, or FSGS. Scarring in parts or segments of some, that is focal glomeruli, while others look normal, is the defining pattern. FSGS is a common cause of steroid-resistant nephrotic syndrome, can progress to end-stage kidney disease, and may recur after transplant. Minimal change shows normal light microscopy. Post-strep is a nephritic pattern, and this biopsy is clearly abnormal. Question 4. A 55-year-old man presents with heavy proteinuria, a low albumin, and generalized edema. A renal biopsy shows a thickened glomerular basement membrane, and blood tests are positive for antiphospholipase A2 receptor antibodies. Which diagnosis is most likely? Option A, minimal change disease of childhood. Option B, acute post-streptococcal glomerulonephritis. Option C, membranous nephropathy. Option D, a simple lower urinary tract infection. Pause here and choose your answer. The answer is C, membranous nephropathy. In an adult, nephrotic syndrome with a thickened basement membrane and positive anti-PLA2R antibodies is characteristic of primary membranous nephropathy. Minimal change is a childhood disease, post-strep is nephritic, and a urinary tract infection does not fit. Importantly, membranous nephropathy carries the highest risk of venous thromboembolism of the glomerular diseases. Question 5. A child on several months of corticosteroids for relapsing nephrotic syndrome has developed a rounded moon face and weight gain around the trunk, and his parents report he is more irritable and growing slowly. How should the nurse best interpret these changes? Option A. These are recognized side effects of long-term steroids. Option B. These changes are completely unrelated to his treatment. Option C. They prove the nephrotic syndrome has turned cancerous. Option D. They are simply the normal growth pattern for his age. Pause here and choose your answer. The answer is A. These are recognized side effects of long-term steroids. A moon face, central weight gain, mood change, and slowed growth are classic corticosteroid effects, along with high blood sugar, infection risk, hypertension, osteoporosis, and cataracts. They are treatment-related, not unrelated, not a sign of cancer, and not normal growth. And they are exactly why we turn to steroid-sparing agents. Question 6. A 58-year-old man with membranous nephropathy has a serum albumin of 18 and very heavy proteinuria, with no active bleeding or bleeding risk factors. The team is discussing how to prevent a major complication. Which preventive measure is most appropriate? Option A. Encourage strict bed rest with no movement at all. Option B. Withhold all fluids to reduce the swelling quickly. Option C. Consider prophylactic anticoagulation to prevent clots. Option D. Start a high-salt diet to raise the blood pressure. Pause here and choose your answer. The answer is C. Consider prophylactic anticoagulation to prevent clots. Membranous nephropathy has the highest thrombotic risk of the glomerular diseases, and a very low albumin of 18 raises it further. So prophylactic anticoagulation is considered when bleeding risk is low. Strict immobility would actually increase the clot risk, and fluid restriction or a high-salt diet do nothing to prevent thromboembolism. Question 7. An adult with nephrotic syndrome has persistent moderate proteinuria and a blood pressure at the upper limit of normal despite other measures. The team wants a drug that both lowers protein loss and protects the kidney. Which class of medication is most appropriate? Option A. A long-term broad-spectrum oral antibiotic. Option B. A regular non-steroidal anti-inflammatory drug. Option C. A high-dose oral potassium supplement. Option D. An ACE inhibitor or angiotensin receptor blocker. Pause here and choose your answer. The answer is D, an ACE inhibitor or angiotensin receptor blocker. These drugs lower the pressure inside the glomerulus, cutting proteinuria and blood pressure and protecting the kidney over time. A long-term antibiotic, an anti-inflammatory drug, which can actually worsen kidney function and proteinuria, or a potassium supplement would not help and could cause harm. Question 8. A child with nephrotic syndrome has tense, severe edema with scrotal swelling and difficulty walking and is very uncomfortable, but he is not hypovolemic. The team decides to relieve the severe fluid overload. Which treatment approach is most appropriate? Option A, give a rapid, large intravenous fluid bolus straight away. Option B, IV albumin, then a diuretic with careful monitoring. Option C, withhold all treatment for now and simply wait it out. Option D, start vigorous physical exercise to move the fluid along. Pause here and choose your answer. The answer is B, IV albumin, then a diuretic with careful monitoring. For severe symptomatic edema, intravenous albumin followed by a diuretic such as furosemide draws fluid back into the circulation and removes it, while we watch closely for hypovolemia and overload. A large fluid bolus would worsen the swelling. Doing nothing leaves him distressed, and exercise cannot shift this much fluid. Question 9. A child with nephrotic syndrome is currently on high-dose corticosteroids, and a live vaccine such as MMR or varicella is now due. Which is the most appropriate advice? Option A, withhold live vaccines now, give inactivated ones only. Option B, give every scheduled vaccine today, regardless of the steroids. Option C, give the live vaccine at double the usual dose to be safe. Option D, never give this child any vaccine again in the future. Pause here and choose your answer. The answer is A, withhold live vaccines now and give inactivated ones only. Live vaccines like MMR and varicella are contraindicated during significant immunosuppression, such as high-dose steroids, because the weakened organism can cause infection. So they are deferred until immunosuppression is reduced. Inactivated vaccines such as pneumococcal are recommended and safe. Giving live vaccines now, doubling doses, or never vaccinating again would all be wrong. Question 10. Parents of a child in remission from nephrotic syndrome test the first morning urine at home with a dipstick. 1 week, they notice 3+ protein on 3 consecutive mornings, and his eyelids look a little puffy again. What does this most likely indicate, and what should they do? Option A, nothing important, they should simply stop testing. Option B, severe dehydration, give a large salty drink now. Option C, a relapse, they should contact the kidney team. Option D, a urine infection, start leftover antibiotics at home. Pause here and choose your answer. The answer is C, a relapse, and they should contact the kidney team. Heavy 3+ protein on the dipstick for several consecutive days with returning puffiness signals a relapse. This is exactly why parents are taught to monitor the morning urine at home and to contact the team promptly so treatment can restart. It is not something to ignore, not dehydration, and not a reason to start leftover antibiotics. Let's recap nephrotic syndrome part 2. Steroid resistance means no remission after 4 to 8 weeks of steroids. For frequent relapse or dependence, add a steroid-sparing agent such as a calcineurin inhibitor, cyclophosphamide, MMF, or rituximab. FSGS is steroid resistant and can progress to end-stage disease. Membranous nephropathy in adults is anti-PLA2R positive and carries the highest clot risk, so consider anticoagulation when the albumin is very low. Watch for steroid side effects. Use ACE inhibitors or ARBs to cut proteinuria and relieve severe edema with IV albumin and a diuretic. Avoid live vaccines during immunosuppression, but give the pneumococcal vaccine. And teach families that 3+ protein on the home dipstick for a few days means a relapse. Call the team. Keep going, and remember, we don't pass alone, we pass together.